morning, and thank you. And many thanks to Dr. Wander for his graciousness in inviting me and for the honor given to the college to be here. It's a very daunting task for me to follow Dr. Nanda. Having spent time in Dr. Feigenbaum's lab in ECHO, Dr. Nanda has been a role model for me for years. So thank you, Dr. Wander, for the honor, but I can't believe you put me on right after Dr. Nanda. So we will change gears a little bit and talk about the use of chest pain centers and protocols to improve care. Much as you have here in India, we have difficulty often translating efficient care to patients who present with chest pain who don't clearly have ischemic symptoms and who often, in our situation, utilize a lot of resources in overutilized facilities. So we've come up with some approaches that may be helpful for you. They have been for us. And briefly, I'm going to review some of the guideline-directed care, give you an example of what we've utilized in our center and others utilizing protocols, and what our outcomes have been, our challenges, and how we've done it. And then review some data that might be useful going forward. Much of what I'm talking about is based on the 2013 focus guidelines from the ACC and AHA regarding treatment of non-STEMI, but we also have newer guidelines regarding imaging. Firstly, remember that when a patient presents with possible acute coronary syndrome or chest pain, that we look preliminarily at the patient with regard to an electrocardiogram and biomarkers. We utilize in our centers now troponin, no longer utilizing CPK. Because of the rapid rise and the sensitivity of troponin, it enables us to move more rapidly. And again, based on guidelines from several institutions, generally we're doing these very rapidly. No longer the old protocol of every 8 hours times 3, but rather a much more rapid protocol. We also try and triage our patients very rapidly when they present. In this case, utilizing the TIMI score, which has been very well validated, giving us a number of variables that tell us the likelihood of a patient having an event. Now, I will tell you that in our centers, we initially utilized the TIMI risk score, and we've migrated to utilizing a newer scoring system called the HEART score, which was actually designed specifically for patients with chest pain and not necessarily those with acute coronary syndrome. I don't think it's really important whether one uses one scoring system versus another. I think it's more important that you have an objective methodology for looking at patients who present and deciding immediately whether they're high risk and need to be admitted to the hospital, or whether they're at lower risk or perhaps intermediate risk and can be managed in a different type of setting that I'm going to talk to you about. Once the patient has been excluded from acute coronary syndrome, some sort of workup needs to be done. I'll call your attention here to the point that the guidelines suggest that some sort of a stress test to provoke ischemia is generally indicated, but sometimes this could be done as an outpatient to free up resources at the hospital or emergency department. But if done, generally recommended that this be done within 72 hours. Now, this is fairly fresh off the press, and some of you have seen this, looking at imaging, different imaging modalities in current context. And these we've incorporated in as well. I won't go over all of the details except to say that these rapid use of initial electrocardiograms, but avoiding sometimes some of the additional imaging which might cost money, delay diagnosis, and sometimes expose the patient to additional radiation or other issues. Our goals fundamentally are most importantly to try and improve patient care, but we also are trying to work to improve the efficiency of our physicians and improve the facility management and efficiency of our emergency departments, which are often overcrowded, and our hospitals as well. In our facility, this was the old paradigm. The patient would present to the emergency room, say, I have chest pain. The emergency room physician would say, yes, you've got chest pain. We don't know if it's cardiac. We'll get you evaluated. Next, one of our hospitalists would come down and say, yes, you have chest pain. We don't know if it's your heart. We'll get you seen by cardiology. The cardiologist would come, sometimes the next day, and say, you've got chest pain. We'll get a test. And at this point, the patient is hungry, scared, confused, and perceives this as disjointed care and really begins to wonder if we know what we're doing. So we've struck out to try and correct that conception by utilizing a guideline-driven, physician-directed program, and we utilize facilitation by advanced care providers, physician assistants, and advanced care providers, nurse practitioners, to try and help us move rapidly, get into the protocol, and evaluate these patients safely and rapidly. In our system, we utilize a protocol-driven approach based on national guidelines that have been validated, but then approved locally so that there's buy-in from the physician. We utilize dedicated units that are specifically designed to deal with these patients, and they're staffed with advanced care providers and staff that are focused on dealing with this specific problem, which for us is a huge issue. Without going over our entire inclusion-exclusion criteria, I'll just say that patients who present who are unstable hemodynamically, have elevated biomarkers initially, or electrocardiographic changes that are highly suggestive of active ischemia, uncontrollable chest pain, altered mental status, or really high-risk people are not who we are looking at. Those are the traditional patients that we admit to the cardiac floor and undergo the routine evaluation. We're trying to take that large body of patients that present with chest pain of indeterminate cause. We're still not certain if they're acute coronary syndrome, and triage these in a rapid manner. We utilize our advanced care providers that are working from a modified appropriate use criteria. We have a cardiologist on call each day that covers this unit, and that physician can, at his or her discretion, alter the protocol, and we sometimes do because we look at the patient and realize that she doesn't fit into the guideline because of some discrepancy or difference, so that we're individualizing care. Generally, I will tell you that our data show that depending upon the month, 75 to 90% of our patients fit right into the protocol, and then a percentage do not because of some clinical nuance that the physician picks up upon. Outpatient stress tests are often done to try and facilitate rapid management, but we are very sensitive to the fact that some of our patients, just as some of yours, may have issues that would prevent them from coming back within 72 hours. These might be transportation or financial or social issues, and we do not let those people leave without testing. So a busy slide here, but my staff, our advanced care providers, receive the patient. They begin the workup immediately. So if I'm in the cardiac catheterization laboratory and I'm busy, there is no delay. These patients are seen by the nurse practitioner. They begin the chest pain protocol. I'm notified immediately. And then the third piece of this is that we then get together, discuss the patient, I evaluate the patient, and then we move forward and try and facilitate evaluation and workup. Again, a very busy slide, but essentially to work you through this, we initially do the history, the physical exam, the initial EKG, and point-of-care troponin. High-risk patients are admitted. Moderate to low-risk patients are placed into our cardiac decision unit or chest pain unit for immediate evaluation by our advanced care providers. In our current protocol, and I emphasize current because this evolves, we utilize electrocardiography at 0 and 6 hours, troponins at 0, 3, and 6 hours. I'll digress there and say that in some patients who are felt at very low risk, at the discretion of the cardiologist at 3 hours, we make a decision to go on to some sort of provocative testing. Our standard protocol is 6 hours. At 6 hours, if it's positive, if the markers or the EKG are suggestive, patient is admitted for further evaluation. If not, we move rapidly to some form of testing, and then we try and move toward discharge if appropriate, or admission if needed. Our protocols, based on the appropriate use criterion from the ACC, try as much as possible to utilize a standard exercise stress test in those patients that are low risk, able to exercise, and have an interpretable EKG. When we began our program, our data showed that if a person presented to my institution with chest pain, the probability of getting nuclear imaging was about 95%. The problem with this in the low-risk patient is that it takes a lot of extra time, it's extremely expensive, and it exposes the patient to a significant amount of radiation that in some cases is very helpful, but in some other cases is not warranted. So our default position for the low-risk patient is a standard stress test. As many of you know from the literature, the data show that in low-risk patients with an interpretable stress EKG, if it is negative, the predictive value for negative stress EKG is extremely good for determining low likelihood of recurrent event. Now that's different than trying to diagnose the presence or absence of coronary disease. And I should point out that what we're doing in our chest pain centers is not necessarily diagnosing does the patient have coronary disease, but rather initially triaging and deciding is the chest pain ischemic. If no, then the patient can be referred to the cardiologist to determine does the person need some other testing to determine high risk for coronary disease and appropriate treatment. We utilize still a significant amount of nuclear stress imaging for the indications that you see here, including the presence of known coronary disease. And we utilize in our system a lot of stress echocardiography. It's very cost effective. It's rapid. It doesn't involve any radiation. It's very helpful in people with structural heart disease, valvular heart disease, and those in whom we're concerned about left ventricular function, especially if a lot of the presenting complaint has to do with dyspnea. In our center, we reserve coronary CTA for patients who have been readmitted within 12 months, who had previously come to our chest pain center, had chest pain, and a negative workup. In that case, those patients immediately go to our CT scanner for coronary CTA. As I'll show you in a few moments, a number of chest pain centers, at least in the United States, utilize coronary CTA as an initial evaluation, and the current guidelines consider this to be an appropriate utilization of resources. It's expensive. It does involve ionizing radiation, although the radiation doses in our labs have dropped from about 20 to about 2 millisieverts, and it does involve contrast dye. So we think about it twice, but it is an alternative. So the key elements for us in our chest pain centers are these are people who are at low to intermediate risk, not high risk. They have negative troponins at 0, 3, and 6 hours, occasionally at 0 and 3. They can't have new electrocardiographic or dynamic changes, and they have some sort of functional testing early on within 72 hours, and typically in our center, usually within about 7 hours. The tests are per protocol, unless overridden by the attending physician. And as I told you, that happens 10 to 25% of the time. And our process, importantly, is facilitated by advanced care providers. Utilizing a team-based approach, I can't oversize the importance, at least in our centers, of this last piece. I often, as many of you, go to the hospital early in the morning and have a large number of patients upon whom I need to round. They may need me in the cath lab. They may have someone in the ICU that needs my care, and yet there are 4 patients waiting in the emergency department who have chest pain who need to be evaluated. For me, the ability to have one of my nurse practitioners down there triaging those patients very rapidly and beginning the workup while I'm still working on other things is extremely helpful for me personally. It's great for the patient and, importantly, for the facility. We're dealing with these patients and eliminating these blank times that we had before. So our data show that before we initiated this type of program, it took us roughly 36 hours to process a patient with chest pain who presented. Once we got our protocols in place, that dropped down to about 17 hours in our chest pain centers, and it's the same workup. All we had done is eliminate times when nothing was happening to the patient. Exactly the same workup, other than the fact, as I told you, that sometimes in our old system we'd utilize imaging techniques, and utilizing protocol-driven guideline-driven protocols, we're sometimes eliminating what we think are unneeded imaging techniques. Now, this is a really interesting slide because it wasn't totally unexpected to me that when we put this protocol in place, we'd shorten the length of stay for patients who were in our chest pain centers because of all the things I've shown you. What's interesting is those patients in our centers who are not assigned to the chest pain center and for some reason or another are simply assigned to one of the hospitalists and cardiologists, the usual care, if you will, have substantially dropped their length of stay as well. Not as much as in our chest pain centers, but they've dropped it. And the reason for that is a change in culture because of institution of guideline-driven protocols that are based on good science. So all of our physicians now have bought into the idea that instead of simply randomly looking at a patient and ordering things, we really are trying to think through and leverage the advantage that we have of having carefully developed guidelines that help teach me the best way to care for patients. So this is a slide, obviously, that I showed to our finance people at the hospital when I have to justify the costs of such a program. In 14, I saved about 700 bed days. In 15, we saved 1,430 bed days, and that includes one system, LMH, which was only online for a very short period of time. So we're ramping up and continuing to save beds, and as I say to our emergency department physicians, when they've got people sitting in the halls because they can't get a bed upstairs, if I can save bed days, the guy with a broken leg can then be admitted to the orthopedic service. So we're trying really in doing this not simply to treat our chest pain patients, but all the patients that present to our facilities and improve what's going on. Our safety data are good. We have no deaths or myocardial infarctions in patients who are discharged, and we have a 30-day readmission rate it ranges from 0.2 to a high of 2%. So these people really generally don't come back. If they do, they get a CT scan, as I mentioned to you before. So I told you about the old paradigm, the patient who comes in and says, I'm confused, what do I have, and goes through a rigmarole and is hungry. Our new paradigm, and this is what happens in our system now. The emergency room doctor says you have chest pain. We'll get you evaluated by our team that specializes in this. My nurse practitioner goes down and said, Mrs. Jones, you have chest pain. Here's exactly the roadmap of what we are going to do to evaluate you in a very linear and organized manner. The cardiologist comes in, and in a very efficient manner, I can go in. The patient's already had a workup. I can evaluate the patient, say, here's what we're going to do. The patient's perception appropriately is that there is a plan, it's very linear, and these people know what they're doing. Now, they knew what they were doing before, but the patient didn't know that. And it really does make a difference. So our patients are much happier, and this is the real goal for us. Now, there are a few challenges. Sometimes if you change a system and you change a culture of the way you've cared for patients, physicians revolt because we're sort of independent-minded. And so you really have to get local buy-in if you're going to do something like this. You have to have the availability of facilitators, in our case, nurse practitioners or physician assistants. I personally feel they've come down the pike. This is not really new, but Dr. Budoff and his colleagues from UCLA in 2008 produced Accuracy, which essentially confirmed what we now know, that is that among patients with an intermediate risk for coronary artery disease, utilizing coronary CTA is an effective mechanism for really eliminating severe disease, so it offers a real option. In 2011, the CSTAT study showed that not only could you eliminate severe disease, but if you followed these patients longitudinally and they had a negative CTA, this was an effective way of ensuring to the patient that they were not going to have a problem. Now, my friend and colleague Pam Douglas from Duke led the PROMISE investigators publishing the PROMISE trial that started to look in a randomized way what would happen if one employed, on the one hand, an anatomic strategy where out of the box you decided to do CTA versus functional testing. In the PROMISE trial, the functional testing was left to the discretion of the physician. Essentially, what happened in this study was that there was no difference in the primary endpoint of death, heart attack, unstable angina, or major complications. So there was no particular advantage or disadvantage to CTA, and that went out a long time. Now, there was a difference in the need for use for invasive coronary artery disease. Utilizing CTA eliminated a significant number of coronary angiograms, and their conclusions from the authors are what you see here, that CTA is a viable alternative. At least in their study, it didn't show any great advantage other than the potential financial advantage of avoiding an invasive test. Pam and her colleagues followed this up with the platform study, which was published in the SC journal, utilizing functional flow reserve by CTA. So taking CTA from the initial purely anatomic realm over to the physiologic realm and determining whether or not stenoses were significant. A similar protocol, only a little bit more complicated, and that is that the cohorts were broken into one cohort that had a planned non-invasive test, and in those, half of those underwent the standard non-invasive test, half of those underwent FFR-guided CTA, and then based on the results, some of them went on to invasive procedures. The other group were a group that were going to be a planned invasive coronary angiogram, and those two were randomized either to that planned coronary angiogram, ICA, or FFR-guided CTA, and then the algorithm followed based on the results. Now, what they saw in this study was that if there was a planned non-invasive test, there really wasn't a great deal of difference in what happened. You can see on the left-hand panel that there was no significant difference. The biggest difference came in the group where there was a move toward planned ICA, where there was a marked reduction in angiography in the CTA group. Now, importantly, if you look at the red bar on the right panel, you'll see that the findings of obstructive coronary disease, the percentages, are exactly the same in the CTA FFR group as they were in the invasive coronary angiogram group. So they were able with this technique to detect these stenoses and guide therapy. So they enrolled a symptomatic but intermediate risk group. They had similar results, no difference in MACE, but they did find in this case, because FFR was always used in their CT protocol, that if the patient required PCI or CABG, they had more FFR data. The other place that we're looking very carefully, and many of you follow this and may be more expert on this than I, is the emergence of high-sensitivity troponin. We know that from TRAPID AMI that serial testing of troponin T, along with a modified heart score, we talked about that, can identify a group that's at very low risk. And the back study, and this was very interesting, at 1 hour, a negative high-sensitivity troponin had a negative predictive value of almost 100%. We're watching this very carefully in our chest pain centers. I showed you a moment ago that our protocol for troponin is 0, 3, and 6 hours. Depending upon follow-up from the back study, we may actually migrate to a 1-hour protocol. So I also showed you slides where our length of stay had shortened to 17 hours. I may be able to get that down to 2 hours. So this is a dramatic breakthrough. We're looking for confirmation to move forward. On the other hand, Sweetheart has taught us that a small rise does infer increased risk, so we have to be careful with these. So in our opinion, the way to make these chest pain centers better is to utilize and leverage the available science, the translation of that science to action by guidelines and appropriate use criteria, but you've got to get local buy-in. We find it's helpful to have a dedicated unit, the facilitation by advanced care providers. I told you practically why I think that's crucial. You've got to have physicians who are going to champion this. The hospital has got to believe that they're going to get some return on investment. So I've already shown you the slide that you need. If you want to do this, you've got to show them the beds saved. You've got to have buy-in with regard to efficiency and quality from the physicians. They have to believe in this and follow the science and be willing to evolve your protocols. So that's a quick walkthrough of what we've done in our center. It's actually a pretty good example of a number of centers around the United States and some outside the United States, and perhaps many of you have similar results as well. We have found that our patient satisfaction has gone up. They're much happier. Our physicians are more efficient and not stressed out because they need to be two places at one time. And we're able to free up some space in our hospitals for patients who really need to be admitted. So thank you very much this morning